Hey guys, we're going to get started in just a few minutes. I'm just letting a few more people join. Thanks for meeting with us today. I will come back shortly and we'll get this started. Hey guys, Dr. Haverland here. I'm just letting a few more people join and we will get started shortly. Thanks for being here. Hey you guys, Dr. Haverland here. I'm just letting a few more people join and then we'll get started in just a few minutes. All right, guys. So I think we're going to go ahead and get started. We have a few people still kind of coming in for the webinar. I am Dr. Rachael Haverland. Thank you for meeting with me today. Today we're going to talk about a topic that I think is really important. important to discuss. And this is talking about, why am I still in pain after surgery? And, endometriosis excision surgery is the gold standard for removing the underlying etiology of the endometriosis cells. But sometimes there is residual pain that is left over. So talking kind of through this, what we're missing, what are next steps, maybe other diagnosis that may be contributing to some of the pain, I think is really important. This is about an hour-long webinar. So I'll be talking to you guys for the next hour, hopefully letting you guys learn something new about endometriosis, but really just advocating for endometriosis. I love talking about endometriosis. This is my passion. I feel like this is a very underserved area of women's health. So I hope that over the next hour, you get something out of it. What I would like is for this to be interactive as well. So if you have any questions, comments, anything that I talk about that doesn't make sense, I'd love for you to use the chat function. So the chat function is a way to communicate with me, and I'll be checking it randomly throughout this webinar. To interact with you, answer some questions that you may have. But I would love to get to know you more. Sometimes it's fun to see where people are from. About half of my patients now are from out of town or out of state. This morning I had a Louisiana and an Arkansas patient. I've even had one from Chicago and California earlier this week. So really from all over. A lot of my patients are still Texas local, but Texas is so big, it doesn't necessarily mean that you're in the DFW area. So thank you for joining with me. This is one nice thing about technology, is being able to talk to people all over the country and really all over the world, and share information about endometriosis. So without further ado, we will get our webinar started, and I'll be adding people as they kind of the stragglers as they come in. But what we're going to talk about today is, why am I still in pain after surgery? So you got cut open, you followed every rule, you're still in pain. And here's the truth that no one told you about recovery. You were told that surgery would fix everything. You followed every instruction. You rested, you medicated, you waited, but the pain is still there. You're exhausted, more confused, and you're starting to wonder if this is your new normal. And that's petrifying. You trusted the process, you did everything right, but you were never given the full roadmap to recovery. So this webinar exposes what's really happening inside your body after surgery, why pain can persist even after the doctors say that you're fine, and how to finally take control of healing before things get worse. So by the end of this webinar, hopefully you'll know why your pain didn't disappear after surgery, the most common recovery mistakes that women don't know that they're making, and what to do this week to get back on track and to actually heal. And so if you've ever been told, just give it more time while your body is screaming for help, this is your turning point. This is all explained, hopefully without medical jargon, false promises, or, that you have to live with it, because that's simply not true. So kind of going back, to why am I still in pain after surgery? I think this is a very incredibly important topic, because while surgery is the gold standard for endometriosis excision and removing the disease, there's a lot of other modalities that contribute to pain after surgery. And we do have treatments that can help. And so it's really important to make sure that your doctor understands surgery, the recovery process, but also the other etiologies and pain symptoms that endometriosis can contribute to in the body. And so, just kind of getting started, what if the surgery that was supposed to fix you didn't fix the problem at all? And I think that that's a very bold statement, because, women that undergo endometriosis excision surgery, we talk about removing the root cause. We find pathology that shows endometriosis, but, you were promised relief. Months later, though, you're still bloated, you're still in pain, you're waking up exhausted, and your doctor says it's just healing, but it's not. You're not crazy. You just weren't told the full truth about what happens after surgery. And it's really important to have these discussions with your patients about anticipated and expected recovery. I'm Dr. Rachael Haverland. I'm a board-certified gynecologic surgeon and endometriosis specialist. I've helped almost thousands of women recover from complex surgeries, when the medical system stopped paying attention. This isn't about blaming your doctor. It's about finally understanding why your body is trying what your body is trying to tell you and how to fix it. So by the end of this session, hopefully you'll understand why surgery isn't the final fix, the red flags that means your recovery is off track, and how to finally create a recovery plan that works, not guesswork. This is evidence-based plan after surgery to help you get the most outcome. So the first thing I'm going to talk about is why surgery isn't the finish line. There's a misconception that once endometriosis is removed, I should feel better. And there's a few caveats to this. The truth is, surgery, when done with an experienced endometriosis surgeon, can remove what's visible. But removing these underlying lesions does not mean that there may not be some residual inflammation left behind, nerve sensitivity, nerve damage, hormonal chaos. So the gold standard of endometriosis excision surgery is to remove all visible disease. I will say 99% of the time with my surgeries, I'm able to do this. I feel very confident with endometriosis surgery. I get wide margins around the disease. I am, able to identify the disease because the disease can look different for different women. Women that are very young or postmenopausal women, sometimes the endometriosis looks more like a scar tissue or a clear blister, or it's a little bit more subtle. Classic endometriosis is what we were taught in medical school and in residency, and that's more obvious. But one, it's important to be able to identify the endometriosis, and then two, to remove it with wide margins. I remove all visible disease. I try to get wide margins around this visible disease that hopefully that I'm catching some of this microscopic cells too. So removing the underlying cause is the first step to seeing improvement, removing the underlying etiology. But there definitely can be nerve damage. There's still inflammation, and the nerves take a very long time to heal. This tissue remodeling may take up to a year. Nerves heal 1 to 2 centimeters a year, and so it can really take a long time for these nerves to be able to reset. So one of my patients came to me 6 months post-op, and she was, she had an excision surgery with a different surgeon, but she was terrified that she had made a mistake. And I reviewed her pathology report. I reviewed her pictures. The issue was not surgery. It was the missing aftercare piece that nobody told her about. And it is imperative to discuss this and use a multimodal approach to tackle endometriosis, because endometriosis is not a pelvic disease. It is not a disease just of the pelvis. It is a whole body inflammatory disease. It is affecting you in many different ways that you don't even know. And so it's imperative to attack endometriosis with this multidisciplinary approach to get your best outcome. So surgery starts recovery. It does not finish it. And I have this conversation with all of my patients. I give them outlines talking about next steps. But it is imperative to have a plan after surgery, because surgery and surgical recovery is important, but it's imperative to manage this endometriosis long term. Endometriosis technically a disease that is not curable. Even though I remove the endometriosis cells, your body still has some inflammatory properties, and we don't always know why. But it's imperative to manage this lifelong, because even though technically endometriosis is incurable, it does not mean that your symptoms have to be as severe as they are now. And that's the most important part, is managing your symptoms, improving your quality of life. So yes, you may have endometriosis for the rest of your life because technically it's not curable, but finding a way that it doesn't negatively affect your life, that you can do the things that you want. You can accomplish the things that you want to accomplish, whether it's fertility or quality of life or decreased pain or moving up in your job and being able to have more focus in some of these different areas. It's very important to sort of set your expectations for endometriosis. And different patients, obviously heal differently and have different outcomes. And some of that is the work they put in. Some of it's related to how their body responds to the disease. But it's very, very important to have a plan after surgery for next steps. Again, if you guys joined us late, I'm Dr. Haverland. Please feel free to use the chat function on the side so that this can be interactive. If there's something I talk about that doesn't make sense or that you have questions about, just let me know. So The next thing I want to talk about is real signs that your recovery is off track. So there's a misconception that it's just healing pain. So yes, you do need an initial amount of time to heal from surgery. A lot of like the initial pain and ailments after surgery will resolve by the first few weeks, usually by 6, 8 weeks, most of the inflammation from surgery has gone down. And at that point, you do need to work on next steps. So there's a difference between discomfort and dysfunction, and no one teaches women how to tell the difference. So after surgery, there's a large inflammatory response. Your muscles aren't functioning as well as they should. Um, Sorry, excuse me, I have to plug in my computer because I don't want it to die. Okay, sorry about that. That was important. And so, this huge inflammatory response after surgery, there's inflammation, your nerves are inflamed, your muscles are not working the way that they're supposed to. But the dysfunction is what is important to identify. So this discomfort from surgery should improve over these next few weeks, but dysfunction is another idea that you should be very aware of. So dysfunction can include difficulty having a bowel movement, difficulty starting a bowel movement, urinating. Does your urine stream start and stop? Is it not consistent? Do you still have urinary urgency? Do you have frequency? Are you having painful intercourse still, despite the endometriosis being excised? What is your bleeding pattern looking like? Do we need to look at other etiologies of your hormones or look for other diagnoses like adenomyosis? But that's where the dysfunction problem should be evaluated. So inflammation after surgery should slowly improve with time. But once you get out to that 6, 8 weeks, these other etiologies that are associated with endometriosis should certainly be addressed. Like we mentioned before, surgery is the start, not the finish line. So I had a patient recently. So she came in and to me, and honestly, she was unable to walk. She had like stabbing, sharp shooting pain. She came to me from another clinic. Her doctor said, "You're fine." They did some imaging, couldn't find anything wrong, in the imaging. But unfortunately, she had a lot of scar tissue around her sciatic nerves. Unfortunately, we could not see that, with imaging. But after surgery, wherever the scar tissue and formed, it was around her muscles and in the pelvic floor. And there's a few different ways that you can evaluate this. One is, a good thorough physical exam. Another one is using pelvic floor physical therapists, where I think are imperative in both the preoperative and postoperative management of endometriosis, especially when it comes to endometriosis surgery. But identifying that there's scar tissue that was negatively affecting these nerves around the sciatic area and in the pelvic floor. This patient specifically didn't have to come back to surgery. We didn't have to go and remove the scar tissue. She was able to see benefit by seeing a pelvic floor physical therapist that was very well educated about endometriosis and women's anatomy, was aggressive in treating her and managing her. But if she hadn't undergone physical therapy or never been told about pelvic floor physical therapy, she likely wouldn't have seen the benefit that she did. And so it's very important to understand what your resources are after surgery, and hopefully have a doctor that can help guide you in the next steps, because endometriosis is a very complex disease. It is not a one size fits all, and it's not an algorithm. Like there's not an algorithm that works for endometriosis, because every patient is so individualized. The way that the disease affects women is individualized. And so making sure that we're giving you all of your options, but also able to identify when something is not just discomfort, when it is dysfunction, and understanding what next steps can be used to treat it. So pain after surgery is not failure. It's a signal, and you cannot ignore it. Ignoring it only makes things worse. It is imperative to identify this dysfunction and move forward with next steps. So again, I'm going to jump over to the chat and answer some questions with you guys. My name is Dr. Haverland. I am owner of Endometriosis Center of Excellence. I focus only specifically on endometriosis. In the chat, you'll see a link to potentially schedule a visit with me. So this link is not a visit with me directly. I just want to make sure that that's clear. This link is a time to schedule a meeting with my front office manager. Her name is Cyrus, and she'll meet with you. She'll talk to you about scheduling a visit with me. She'll go over your insurance, and then she'll get you on the book. So use this link as a time specifically to talk with Cyrus so she can meet with you and go over kind of scheduling and what that process looks like. And she'll ultimately get you on the books. But please note that this link is not a direct visit with me. It is a visit with Cyrus, so that then she can get you on the books and talk to you about scheduling a visit. But I would love to meet with you. Today, we're talking about endometriosis and why some women have pain after surgery. And so it is a very important topic because we mentioned I think surgery has a huge benefit for women. Removing the endometriosis, removing the underlying etiology is imperative for long-term management of endometriosis. However, it is not the final step. It is the start. Endometriosis is technically not a curable disease. However, improving your quality of life, improving the symptomatology, knowing your resources for next steps is imperative. And resources for next steps usually start before surgery and continue after surgery. And we've talked about this in some of my other webinars, but just kind of going through different options for treatment, least invasive to most invasive. One is diet. The food that we put in our bodies causes inflammation. Women with endometriosis tend to have more food sensitivities. It is imperative to evaluate your diet, rather meeting with a nutritionist. I like whole foods diet where you can add or subtract things that you feel like are negatively affecting you, trying to find foods that flare you, foods that your body can tolerate. Gluten and dairy are very common, with endometriosis patients. It doesn't mean every endometriosis patient has these food sensitivities, but I think it starts with diet and getting to the underlying inflammation that's affecting the bowels and the gut, because they all contribute to each other. Next, acupuncture has been shown to be beneficial. Hello? Okay. Next, acupuncture has been shown to be beneficial with kind of resetting some of the nerves and that central sensitization of pain. Out of all of these less invasive modalities for management of endometriosis, both before and after, exercise, I think, is huge. But one of the most important aspects that almost all of my patients get a referral for is pelvic floor physical therapy. Pelvic floor physical therapy is imperative to long-term outcomes. Like I just talked about my last patient who came in with that just debilitating sciatic pain. Her doctor didn't know what to do with her, but pelvic floor physical therapy was the next step. She had scar tissue all around her pelvic floor, affecting those sciatic nerves, and she was able to treat it after surgery with pelvic floor physical therapy. She did not have to go back to have another surgery to remove the scar tissue. And I think that it's very important to understand and know your resources. Endometriosis is complex. It's very much of a whole body disease. And so we have to treat it as such, treat it as a whole body inflammatory disease. Yes, removing the endometriosis surgically, I think, is imperative to long-term outcomes, but it is not the finish line. It is very important to understand the science behind endometriosis, how it's causing this inflammatory effects on your body. And also some of the other
Actually, I'll just talk to you now.
Okay.
Because
Let's go.
I only have a
Hello,
couple minutes, so
I
I
think-
think I'll just come say hi real quick.
I'm Chaz. I'm out of Lake Charles.
You're muted.
Thank you. All right, can y'all hear me now? Yeah. Okay, great. So what actually works for long-term recovery? So that is the next steps. There's a misconception that after surgery, there's nothing left to try. Most women are discharged after surgery without a plan. They're like, I just do surgery on you and then you're done. Good luck. I'm going to remove the endometriosis. But real recovery happens with the right team, physical therapy, inflammation control, and functional care that a surgeon sometimes doesn't have time to explain. And it is imperative to set some of these expectations and to set the plan in place before surgery so that you know what to anticipate and you know what next steps are. Again, all of my patients do get a referral for physical therapy, or most of them do. And I think that it is very important, but also working on, diet. Exercise can be, difficult after surgery, but once you feel like you're able to, it certainly can have a benefit. I also have doctors that I refer to called physiatrists. So they're pelvic, they manage the nerves and the evaluation of the pelvis and kind of how the nerves innervate with pain, the central sensitization of pain. I have a great physiatrist that I usually refer to help with pain management, nerve damage after surgery, and just reset some of this inflammation. And using this multidisciplinary approach is really imperative to best outcomes. So one patient started pelvic floor physical therapy 3 weeks. And we reevaluated her after recovery. When within 2 months, her pain dropped 70%. So it was not just surgical recovery that improved her pain. She didn't start it until 3 months after surgery, which 90% of the inflammation after surgery should be improved by 3 months. But pelvic floor physical therapy gave her that added benefit that she needed. Was it scar tissue mobilization? A lot of it is pelvic floor dysfunction affecting the bladder or the bowels. After surgery, the inflammation in the body sometimes gets worse before it gets better. And I think that it's really important to, to manage next steps and manage expectations. But a lot of that comes with pelvic floor physical therapy, managing inflammation. And we give these kind of next steps ahead of surgery. When you schedule surgery with my surgery scheduler, you get a kind of a package to go through. Rather, it's talking about diet, physical therapy, physiatry, next steps. Sometimes we talk about hormones, depending on if we think that you have adenomyosis, but making sure that we're closing the loop. I'm looking at at some of the chats talking about how women had an ablation surgery and didn't see benefit, and that's unfortunately very common. So the most important step with endometriosis surgery is to excise and to remove all of the disease. So I remove all the disease that I can see visually. I get wide margins around it. I feel very comfortable removing in a difficult locations, whether it's around the bowel, the rectum, the nerves, the ligaments, the bladder. Finding the endometriosis, identifying the endometriosis again, because it can be more subtle and a little bit more difficult to identify the endometriosis and then to remove it with wide margins. Excision is the only evidence we have that shows benefit for fertility outcomes and also for decrease in pelvic pain for long term. And I think it's showing us that removing these cells, removing these underlying etiologies is a very important step. But again, surgery is not the finish line. Surgery is the start. And it is imperative to have a plan set in place so that you get your best outcomes. So you don't have to wait it out. If you've had surgery and you're still having pain, look at next steps. Is there something we're missing? Did we talk about adenomyosis at the time of your surgery? Do you still have inflammation from the uterus that's contributing to your pain? Did we talk about nerve damage? Have you seen a physiatrist? Have you talked about nerve injections in these areas? Have we talked about hormones? Hormones for adenomyosis actually do show some benefit, usually in the form of progesterones. Adenomyosis is a very difficult disease to treat. Sometimes you need higher doses progesterone. Sometimes your body doesn't tolerate the progesterone. But just talking about next steps and what your different options are. But I always go back to the basics and kind of our our plan for managing the inflammation and the functional care. I even have some functional medicine doctors that you can meet with. Have we done everything to evaluate your GI? Have you been checked for SIBO? Like, what are your hormones look like, including your vitamin D and your insulin, and your inflammatory markers? Like, what are we looking at, and what are next steps? And sometimes I don't know the answer, but that's why I have my colleagues that help me. Dr. Rusha Kapadia is a physiatrist that's opening her practice in January and starting to see patients. She is wicked smart when it comes to the pelvic pain management and kind of the central sensitization of pain and managing inflammation. I have physical therapists across DFW. I try to find physical therapists, in different areas of the country where my patients are located. Also finding, nutritionists that understand endometriosis, that understand how your body is responding to foods differently than other patients without a chronic inflammatory disease. But then also talking about adenomyosis and your different options, if that's what we thought was contributing to your symptoms. And again, I don't always know the answer, but hopefully I can have tools to help get you to that point where you can see some benefit. With adenomyosis, sometimes it puts us in a difficult place because we can remove the endometriosis, but if the uterus is still present, you may still have some inflammation of the uterus. Adenomyosis is treated with progesterones or hysterectomy. Sometimes even after removing the endometriosis or the uterus, there's some long-term nerve damage. Being in this chronic inflammatory environment for 10, 15, 20 years can certainly cause long-term damage. And it is important to understand that this may be nerve damage that takes time for remodeling, talking about medications that can help with nerve pain, seeing a physiatrist that can help manage nerve pain or has better options for management, but understanding the complications of surgery and what to look for that's normal, but also what's not normal, what's considered like this dysfunction, and making sure that patients are getting placed in the next steps for their long-term outcome and management. So now that you understand, surgery is not the end, it's the beginning of a process that most women were not prepared for. I have 45-minute to an hour visits with my new patients, and I try to fit all this in, talking about diet and exercise and physical therapy and physiatry and hormones. But a lot of times this could be a specific visit on each of these areas alone, but trying to give patients their resources so that they can find next steps and find answers, meet with a nutritionist that understands, have a high quality pelvic floor physical therapist, meet with a physiatrist that understands the nerves of the pelvis and how endometriosis affects the body. All of these things are imperative. And, a lot of my resources are in DFW, but I'm working on trying to find resources outside of that since so many of my patients come in from out of town. But it's very important to find, to make a long-term plan and understand that surgery is the beginning of a process. Knowing why you're still in pain isn't the same as what to do next. So it's also important to understand the root cause of why a patient is having pain. So I talked about earlier, a patient that had surgery with a different surgeon came in and she was still having sciatic and pelvic floor pain. And we tried physical therapy, but in my anticipation is that it was related to nerve damage from the endometriosis and also scar tissue related to surgery. And she saw a huge benefit with pelvic floor physical therapy. So trying to understand what the root cause of the pain that's still contributing or the root cause of the dysfunction will help you with next steps. Because some people benefit from, most people benefit from seeing physical therapy. Some people benefit from seeing physiatry. Some people need to work more. If your biggest complaint after surgery is bloating or inflammation, kind of working more with like the GI and the overall inflammation of your body. But trying to find the root cause to understanding why the problem is happening that helps you with what next steps are. So, in my practice, I give patients my cell phone. I respond to them. You have 6 months of a concierge practice with me. I try to give you next steps for what we need to do to improve your quality of life. What are we missing? What is the next steps? Is this adenomyosis? Is this a GI? Is this more chronic inflammation? Where is your pain located? Is it consistent with your period? Or is this chronic nerve damage? Do you need to talk to a doctor about taking medications to help with nerve pain. What are next steps? Understanding the why, and then next steps of finding what we need to do next. So I very much try to personalize my treatment plan for every patient. This is endometriosis patients are complex. This is not an algorithm. This is not a one size fits all. And so it's really important to understand what next steps are and what your symptoms are, and kind of personalizing a recovery plan for you, not just before surgery, but also after surgery in anticipation. So again, I'm going to jump over to the chat and answer some questions here, and then we'll kind of get back over to endometriosis and why some people still have pain after surgery. So one of the women asked, what about adhesion? So can pain be caused by adhesions after surgery? And it certainly can. So I am very type A. I'm very specific on trying to make sure that I limit adhesions as much as I can. So I use cold cut scissors. I use a substance at the end of surgery to help prevent adhesions. It has growth factors and proteins in it that helps prevent scarring after surgery. Some of surgical scarring is genetic. When I close people's skin at the end, when I close my port sites, I close everyone the same way. Some people scar really nicely and you can barely see it. Some people are a thick scar. Some people kind of the scar turns a different color than their skin was originally. And so some of the adhesions and scar formation is genetic. Sometimes some of it is certainly surgical technique, which I try to optimize. But no matter how good you are at surgery, and I do surgery a lot. I consider myself very qualified. However, there is going to be some scar tissue left behind, no matter how good you are. And again, it is important to anticipate that and to realize that certainly can be a postoperative concern. Usually pelvic floor physical therapy, scar tissue mobilization can be very helpful with skilled pelvic floor physical therapists. So also in the chat, they put up a link to schedule a visit with me. So this is a calendar invite to meet with my office manager. Her name is Cyrus. So remember, this time that you click on through the scheduling app will be to meet with Cyrus, my office manager. Cyrus is going to talk you through the scheduling process with me, what it looks like, and then she'll get you on the books to meet with me. So I just want to be very clear that this calendar that you're seeing, I would love to meet with you and get to know your story about endometriosis and make an individualized plan for you. But this calendar time will be to meet with Cyrus, and then she will get you scheduled with me. So just to make sure you know that this is not a direct visit with me, but rather to meet with Cyrus and then get on my books. Somebody mentioned talking about vitamin D and the relationship with endometriosis. Vitamin D is a hormone. It's not one that we think about. We always think about of estrogen and progesterone, but vitamin D very much is a hormone, along with the thyroid medications, the medications that cause us to be hungry, like gonorrhea, and the way that insulin responds to our bodies. They are very much interconnected. Most women in the United States are low on vitamin D. Vitamin D can also help with inflammation, but it is important to have these evaluated. And I refer to, rather my primary care colleagues, or I do have some naturopaths that patients meet with to make sure that their hormones and their vitamins are really being evaluated to make sure that they're optimized and they're decreasing the inflammation. Here's a patient. She said, I had endometriosis symptoms for 20 years before I was diagnosed. How do I find out if you have nerve damage? It's very difficult to know. Nerve damage happens in most of women with endometriosis. The question is after you remove the endometriosis, you have surgery for a gold standard of endometriosis excision surgery. Do you still have pain afterwards? Are you still having radiating pain? Does the pain feel sharp, stabbing, shooting, fire? That is nerve pain. cramping, dull, aching pain that tends to be more muscular pain, sharp, stabby, burning pain that's radiating, that's more related to nerve pain. And a thorough evaluation by a pelvic floor physical therapist or a physician or a physiatrist can certainly help guide you in those next steps and kind of evaluate the pelvic floor. Let's see. Is it common or normal to gain 40 pounds after surgery for endometriosis and adenomyosis? That is definitely not common. A small amount of weight gain is common, usually related to fluid retention, but a significant amount of weight gain over a few pounds, especially if it's more prolonged, is likely telling us that there's some sort of hormonal imbalance, rather not just your estrogen and progesterone. It could be your thyroid, it could be your vitamin D, like I mentioned, your insulin. There's some gonorrhea or the medications that make you feel hungry. There's certainly a change, and surgery can initiate some of these changes associated with weight gain after surgery, but usually after a few weeks and the inflammation of surgery goes down, most of the time these hormones normalize. So if there's still after 10, 12 weeks and you're still having these symptoms, I think it would be imperative to see a naturopath, your primary care, to evaluate for some hormone fluctuations and see what next steps are. Let's see. Could full body pain, especially in the hands, be part of an endometriosis flare? It certainly can. So women with endometriosis are more likely to have other autoimmune diseases, including rheumatoid arthritis. I have patients that tell me all the time, pain that radiates to my joints all the way down my feet. And that certainly can contribute to a lot of the symptoms. And so it's usually not endometriosis specifically in your hands, but more of this chronic whole body inflammatory disease that we're fighting. And so the symptoms you're experiencing likely are still related to endometriosis, even if endometriosis isn't in the location that you're feeling the pain. And that's very common. And that's another reason why it is imperative to use this multidisciplinary kind of whole body approach. Remember, surgery is the beginning, not the end. It is very important to set your patients up for success. Talk to them about lifestyle changes. Talk to them about physical therapy. Talk to them about risk of adenomyosis. If they do think they have adenomyosis, what are your next steps? What do you want to do about the adenomyosis? If you have IBS, if you have bladder symptoms, have these thoroughly been evaluated? While endometriosis frequently causes all of these symptoms in one, you can also have more than one diagnosis. It is reasonable to have endometriosis and interstitial cystitis, for example. Sometimes your interstitial cystitis is actually endometriosis and not a true diagnosis of IC, but everybody is different. And so it's really important, again, to understand why the symptoms are occurring, and then you can understand what to do next steps, rather seeing a physiatrist, physical therapy, a urologist, depending on the symptoms you're experiencing. Many times, these less invasive measures, you may not see the full benefit of them until you have endometriosis excision surgery, until the endometriosis is actually removed. You may see some benefit, but sort of hit a wall. And everybody is different. Again, this is definitely not, this is not a one size fits all. This is not an algorithm, because women with endometriosis are very individualized. Not everybody has the same symptoms and not everybody has the same goals. But removing the underlying root cause of the endometriosis with endometriosis excision surgery does frequently give more of a benefit for these less invasive treatment options. Because if you're doing physical therapy, for example, but the endometriosis is still there, aggravating the muscles and the nerves, you may not see as much benefit until after the endometriosis has been removed, and then you'll continue to see more improvement. And this is the same in a lot of the different areas, rather with exercise or diet and bloating, related to physiatry, with managing the nerves. And sometimes they do nerve injections, different ways to kind of decrease the inflammation around the nerves to sort of help reset them with that central sensitization of pain. A lot of times after we remove the endometriosis, if a patient has adenomyosis, sometimes those symptoms aren't as severe, because some of their symptoms we thought were adenomyosis is actually more related to endometriosis. But but everybody's body is different. And so it's important to use this network of treatment plans. Again, most of my, resources are in the DFW area, but I'm working to get more resources outside of that area. I have patients now from all over different states. And so finding, physical therapists, naturopaths, physiatrists in these different areas too, to help with next steps. Of course, I do have some patients that fly to Dallas to come see my referrals, but it certainly is nice if we have more options. And so I'm going to go back to the chat. This asks, do you have a team of doctors that you work with during surgery? Absolutely. And I think every endometriosis specialist, if they are a true endometriosis specialist, should have a team of surgeons. I have a general surgeon, colorectal surgeon, I have urology. A lot of the times I do the surgery myself. I feel very comfortable working on the bowel, working on the rectum, working on the bladder, the small intestines, removing the appendix. With that being said, when you're my patient, you are my family. I don't let anybody come in and operate on you that I wouldn't let operate on myself or my family. These doctors that I work with understand endometriosis, but I never leave the room. Even when the colorectal surgeon comes in, I'm making sure that they're getting wide margins around the endometriosis that I can see visually or that I can palpate, with my instruments, wanting to make sure that they're still getting the margins that I would like them to get. But these doctors that I use on my team are excellent. I have cardiothoracic surgery. You deserve to have high quality care. Endometriosis is complex. Sometimes we get in for surgery and it's more complex than we're anticipating. It's very important to understand endometriosis, but also be able to tackle it in many different ways, whether it's surgically or the inflammation or the nerve damage afterwards. But treating endometriosis as a whole, but starting with the gold standard of endometriosis excision surgery to remove the root cause. And so hopefully you're starting to see more benefit. Let's see. I have a few other people in the chat that I would, let's see. During surgery, do you check all organs along the intestines? Yes. Yes, absolutely, I do. And if your doctor is not evaluating all of these organs, they're likely not an endometriosis specialist. I look at the diaphragm, the liver, the gallbladder, the spleen, the stomach, the small intestine. I look at the the appendix, the colon. I look at the ligaments, the blood supply, the nerves. I look around, of course, the reproductive organs, but that's not the only place that endometriosis lives. And so it's imperative to look at all of these other organ systems in the upper abdomen, feel comfortable removing endometriosis from the diaphragm or other areas that we find it. The gold standard of endometriosis is to remove all visible disease. So if you don't look at these areas, you likely will miss it. And it's imperative to do so. And I find other diagnoses too. Like I found benign liver masses. I found, diverticula on the intestines. If you don't look, you don't know. And it doesn't take much time, honestly, to do a thorough evaluation of all of the organ systems, but you also have to feel comfortable doing so. And so if you're talking to a doctor that doesn't look at these other organ systems, they're likely not doing excision surgery or a endometriosis specialist. All right. How common is it to have endometriosis on the liver? I will say in my practice of a few thousand patients, I probably had it on there 1 or 2 times. So less than 1%. Endometriosis certainly can affect the diaphragm. So the diaphragm is much more common. It's very close proximity to the liver. Endometriosis can be on the gallbladder, which is also close proximity to the liver. And so it's not that uncommon. And the liver is an easy place to evaluate and to look for. If you're removing endometriosis from the liver, it's also important to understand the anatomy of the liver and the different lobes of the liver and the blood supply of the liver. And so usually in that regard, it's when I would call in, another specialist to help me. But it is important to always evaluate. And it's while it's not uncommon, doesn't mean that it shouldn't be evaluated. And so, kind of going back to our main cause here, why am I still in pain after surgery? Likely the reason is one, you did not have a thorough excision surgery and all endometriosis removed. Two, you may have other comorbidities that are also related and contributing to your pain, rather GI symptoms, adenomyosis, bladder symptoms, or residual nerve pain from the damage that endometriosis has caused by being there for years. Two, next is imperative to understand next steps, to make a long-term plan, decreasing the inflammation, optimizing your hormones, treating your nerves, treating the inflammation, treating the scar tissue, managing lifestyle changes, diet, exercise, acupuncture, physical therapy. Sometimes hormones are required to treat adenomyosis, especially if it's present. Understanding how your body is responding to this inflammation, rather working with a naturopath or a physiatrist for next steps is imperative. And it's important to understand all of your resources to understand what next steps are. So, kind of going back, I try to treat my patients with a very personalized consultation. It is very important to treat you individually. Not everybody has the same goals. Not everybody has the same symptoms. The way your body processes foods is not the same as my last patient. So finding a personalized, treatment plan, during our consultation, it usually does involve working with diet, working with physical therapies, working with exercise, but it doesn't mean it's a one size fits all. It's important to uncover what you're missing and build a plan that works for your body individually. So when you meet with me, I spend time listening. That's the first thing I do is I spend 30 minutes listening to the symptoms you're experiencing, your history, what you've tried, what you haven't tried, if you've had surgery for a diagnosis or if it's a clinical diagnosis. We review all of your symptoms and your history. And then we talk about what's keeping you in pain. Is it your goal for fertility and therefore not having the opportunity to treat the adenomyosis at this point because your ultimate goal is for pregnancy? Or is it nerve pain? Or your nerves radiating? Has the endometriosis been there for so long you're starting to have chronic nerve damage? And then creating a step-by-step plan for recovery based on your unique goals in your body. Again, this is very individualized. Some of my patients, their number one goal is for pregnancy. Some of my patients don't desire, their own children. They've had no children by choice. They just want to work on their quality of life and their pain. Some is to preserve their ovaries. The ovaries give us a lot of benefit for longevity. The estrogen that the ovaries produce is protective for our heart and protective for our bones. And so there's certainly a longevity benefit to protecting the ovaries, not just for fertility, but also for longevity and health. So this is not a generic checkup. This is not a one size fits all. I listen to your symptoms. We talk about your goals and we make a plan. And it is important to implement all of these multidisciplinary approaches for the best outcome. Like I mentioned, endometriosis is not a curable disease technically, and it's not a disease of the pelvis. This is a whole body inflammatory disease. So we try to treat it as such. And when we understand that endometriosis is a whole body disease and how this inflammation affects us, whether it's fatigue, chronic pain, headaches, nerve pain, how it affects the bowels, how it affects the bladder. Once you understand how it's affecting you and the reason it's affecting you, then we can understand what next steps needs to be. So this is a focused consultation designed to help you fully understand your pain and map out a path forward with, people that understand, real experts who understand endometriosis. And I think that it's imperative to have doctors and experts that truly understand the etiology behind endometriosis to help you, kind of getting your next step, getting a plan in place so that you can improve your quality of life. So spots for this next month's consultation are limited. Once the schedule fills, the next opening are 6 to 8 weeks out. So please use the calendar here that's placed into the chat. With this calendar, you will have a time to meet with Cyrus. Cyrus is my office manager, and she will talk to you about scheduling and getting an appointment with me. And then at that point, you'll have a schedule to meet with me. But remember, this calendar is the time to meet with my office manager to help get you on the schedule ultimately. But I would love to meet with you. I'd love to talk to you about your symptoms and get a personalized individual plan, for next steps. If you're still in pain, tired of being dismissed, and ready for real answers, click the link now. I would be happy to meet with you. I'm honored that you shared with me this last hour so that we can talk about endometriosis and learn more about endometriosis. This disease is, quite debilitating. It is a disease that affects, hundreds of thousands and millions of women, throughout the world. You are not alone. Endometriosis, it affects 1 in 10 women, maybe even more frequently than that, up to 1 in 8 women. And we do have treatment options. Yes, it is not curable, but we have a plan to help improve your quality of life, to get you to the place that you want to be. Surgery is imperative to remove the underlying cause. Good surgery with excision surgery is very important, but it is not the finish line. It is the start. It is important to use a multidisciplinary approach to treat the endometriosis to get your best outcomes. And I hope that's what we took away from here today is this is a lifelong disease, but managing next steps, understanding what next steps are. Rather, you're continuing to have nerve pain or scar tissue or GI symptoms contributing to bloating or other comorbidities like adenomyosis or long-term nerve pain from nerve damage with endometriosis being present for so many years. Learning what next steps are and finding resources to help you with next steps is imperative. And I try to offer that to my patients and giving them kind of a roadmap for next steps with this multidisciplinary approach, resources to meet with nutritionists and physical therapists and physiatrists. But it's important to understand that it is just as important as surgery as far as longevity and the long-term outcome for endometriosis. So I am looking forward to meeting with you and getting to know you better and listening to your story about endometriosis. Thank you for meeting with me for this last hour. Sorry, it was a little hectic with my muting and unmuting people as I wasn't supposed to, but I appreciate your time and I hope you learned something a little bit more about endometriosis. Again, I would love to meet with you. I would be honored that you chose to meet with me to discuss more about your disease and your goals. You can use this calendar in the chat. Again, this will schedule you a time to meet with Cyrus, my office manager, who will then get you on my schedule. So remember, this calendar time is not to meet with me directly, but rather to meet with Cyrus, who will get you on my schedule. If you already have an appointment in January, you do not need to. You can call and see if there's an earlier appointment, but to be honest, I don't think we have many earlier appointments earlier than that at this point. So I'm looking forward to meeting with you. Thank you guys again for spending this last hour with me. I am, such an advocate for women that have, been diagnosed with endometriosis that are struggling with the disease, and I am so honored to be able to take care of them. So I look forward to meeting you in my office or maybe seeing you at my next webinar, but I hope you'll have a good rest of your Wednesday. Bye-bye.